Good afternoon. Thank you um, for the invitation. So yesterday it was the 7th anniversary of King Saud Medical City Cath Lab. So this case was done yesterday. I don't have any conflict of interest. So this is a 44-year-old male. He is not known to have any past medical history. He was presented to the private clinic with history of chest pain. His ECG at private clinic showed anterior ST elevation MI. He was loaded with antiplatelet therapy and anticoagulation, and he was transported by the ambulance to the primary PCI center. During transportation, the patient had a VF, cardiac arrest. Bystander CPR was started. ROSC achieved after 30 minutes in our ED. The patient was intubated and mechanically ventilated. Central line inserted. Patient started on high dose vasopressor. He is on high dose norepinephrine, epinephrine, and vasopressin. His VBG showed lactate of 9. As you can see here, his ECG, which showed extensive anterolateral MI. And this is his echocardiogram. So this is a bedside echocardiogram in the ER, which showed severely reduced LV function. Four-chamber view also showed severely reduced LV function, TABC of 13 to 14, which gives mild to moderate RV dysfunction. So cardiogenic shock team was activated. So our cardiogenic shock team involved interventional cardiologist, heart failure specialist, echocardiography consultant, cardiac anesthesia, and cardiac intensivist. So our patient was in class E, SCI stage of cardiogenic shock. So he's hypotensive, hypoperfused, had cardiac arrest, and he is on high dose vasopressor. So the decision was made is to implant ECMILLA. So the plan is to put the VA ECMO first, to do the angiogram, and then to insert Impella. So VA ECMO was inserted, 21 venous catheter, and 17 arterial sheath. You can see here the right coronary artery showed only mild proximal disease, and with the collateral to the LAD. His lift system showed unobstructive lift main and LCX, also proximal LAD occlusion, as you can see here in cranial view. Primary PCI was done with one drug-eluting stent with good final result. And then we inserted the Impella just to active LV load, unloading, and to facilitate the VA ECMO weaning. So the patient was transferred to the ICU. He was requiring low-dose norepinephrine. His lactate dropped from 9 to 3.5. He is requiring less oxygenation, and there was no bleeding issue. So for all our patients, after the ECMO and Impella, we'll do CT brain and CT abdomen just to look for any brain insult or if there is any abdominal or hematoma. So our patient was crash and burn patient. He's class E, SCI stage. He had an immediate VA ECMO and Impella just to allow the LV and to help myocardial recovery. So this is proposed to ECMILLA weaning protocol, and we are following this protocol in our hospital. So first we have to see is the underlying condition is corrected or not, and to look for any end organ dysfunction. Is it improved? And then to look for the hemodynamics and vasopressor or inotrope support. Then we'll look to the vital sign and physical exam plus labs. So we're looking for periphery, we are looking for the urine output, and we are looking also for the lactate. Also, chest X-ray is a part of our evaluation for weaning protocol. Then we'll do the ECMO every day. We'll look for the LV, TAB-C, and VTI. We still underutilized hemodynamic or right heart cath, but we have to look to the PAPI, pulmonary capillary wedge pressure, and cardiac index. So if the patient had a low support, we can reduce the ECMO flow to 2 or 1.5. Check how's his hemodynamic. After that, if he is ready and stable from that point, we can decannulate via ECMO. Then after 1 to 2 days, we will check if we can explant his impella. We'll do the same. We'll check his vital signs, his urine output, how's his end organ, and we will reduce the flow of the impella, and then if the patient was stable, then we can explant the impella. And thank you.